Thank you very much. So I would like to also express my condolences for your late king, and also express my gratitude for the organizers. It's really a great honor to be here. So my task today is to talk about opportunistic infections and immune activation with the potential implications for HIV remission. And it was a very easy topic because there are no data, so I can express mostly my opinions, which is wonderful. I think, as you're all aware, and was discussed also from the previous speakers, immune activation is an independent prognostic factor in HIV, and we knew that for many years now. It has been described both as cellular immune activation with markers such as HLA-DR and CD38 or Ki67 or PD1, or soluble markers of inflammation and immune activation. And for just simplicity, I'm going to encompass them all together, saying that immune activation has been actually described as a predictor of HIV disease even prior to seroconversion, definitely in the pre-HAART era in patients with AIDS, also in as an independent predictor of rapid HIV progression in primary HIV infection, and in the post-combination antiretroviral therapy era as an important predictor of death in treated HIV disease, as well as an important predictor of non-AIDS comorbidities that we see more frequently now in treated individuals. In addition, immune activation and inflammation are really intertwined with HIV persistence. As was discussed by Lydie before, this inflammation and immune activation creates a more fertile environment for HIV, and this inflammation drives T cell cycling and activation. Also, activated CD4 T cells are very important reservoirs of active viral replication, but some of them are put to sleep, like Nicola mentioned, and then they become latent reservoirs. And then finally, CD4 T cell proliferation and clonal expansion are important elements of persistence. And we need to keep in mind that this immune activation and inflammation is definitely enhanced by the presence of co-infections, and particularly opportunistic infections. So the real question is, we know from very important randomized controlled trials, such as the START trial and the Temprano trial, that HIV infection has to be treated regardless of CD4 count immediately upon diagnosis. So the question on the ground is really the late presentation of HIV really an issue, and does it still exist? And I hate to be the Cassandra of the meeting, but it still does. So these are data mostly from Europe, from about 80,000 patient cohort, the COHERE cohort, and you can see here the trajectory of the CD4 T cell count at HIV diagnosis over the last decade or so, between 2000 and 2011, and you can see that it has really inched up by from about 300 to about 350. In the meantime, about 50% of the new HIV diagnoses are made at immunologic aids with a CD4 count around 200, and a pretty resilient proportion of patients between 20 and 30% are diagnosed with late disease, including an AIDS defining illness. Could this be just Europe? No, it is actually a worldwide phenomenon, and defining late presentation as a CD4 count less than 350, you can see that actually happens very frequently, but if we look even at less than 200, 1/3 of the new diagnoses in the US are actually made at immunologic aids, and you can see that there is a wide spread between 25% and 60% in many different countries that have been sampled. Specifically, this study looked in Asia, over 4,000 patients in a few different countries, and they defined late presentation as CD4 less than 200, and you can see there is a really persistent 75% of the new diagnosis that is made at fairly late disease. And I think Dr. Nita Ya also yesterday presented data from Thailand showing that it has been a remarkable increase of the median CD4 count at diagnosis over the last few years, but actually the most current one she showed, I think, was 190 or 194, so it was still less than 200. So unfortunately, late presentation and opportunistic infections still exist. And now, how does that tie to the viral reservoir and potential remission strategies? And here is where we going to the lack of data for the most part. But speaking hypothetically, lower nadir CD4 count has actually, this is not hypothetical, has been linked to higher levels of HIV viral seeding and a much larger HIV reservoir, and I believe the next speaker is going to show you a lot of these data. Lower nadir CD4 count is also a strong predictor of poor immune recovery. We know that patients who remain with very low CD4 counts and have persistent immunodeficiency, for the most part, were more likely to have started with a lower CD4 count. And then finally, lower nadir CD4 counts have also been linked with more residual inflammation after antiretroviral therapy, and thus are more at risk for comorbidities and non-AIDS associated adverse events. So all these can be linked to potential cure or remission strategies. As you heard before, strategies that are trying to kick and get the virus out of the latent cells will have to be a lot more potent in order to shock and sort of release virus from a larger overall reservoir. In addition, kill strategies that are trying to use the immune system to actually fight off these latently infected cells are more likely to be inadequate in these patients because they will be more immunodeficient. And then finally, the more comorbidities might be an issue in selecting patients for strategies that are more complicated, such as gene therapy strategies and such, that may be perhaps more promising in the future. So moving now to more specifically co-infections, opportunistic infections, inflammation, and reservoir, there aren't really a whole lot of data, but I thought I would pick something that is extremely common co-infection in HIV and has also been linked to non-AIDS serious events, and that's cytomegalovirus. A very large proportion, the majority of the HIV-infected patients are also CMV seropositive. And in this cross-sectional study, what these investigators looked at was actually seeding of CMV in the semen, so in genital secretions, and they found that people who were seeding CMV compared to those who were not had actually more evidence of a larger reservoir in the peripheral blood, so they had more HIV DNA in their CD4 T cells, and in addition they had more CD4 T cell activation and CD8 T cell activation measured by different markers compared to people who were not seeding CMV in their semen. This was a cross-sectional study. They moved on, then they did a longitudinal study, and now they looked at both CMV and EBV in peripheral blood mononuclear cells at multiple intervals after initiating antiretroviral therapy in HIV patients who actually started therapy at fairly higher CD4 counts. And they found that the people who were positive for CMV in their peripheral blood mononuclear cells had a much lower decrease of their HIV reservoir as measured by HIV DNA per CD4 T cells, and was much different from the ones who did not have CMV reactivation. And it was interesting because there was no really gradient. It was like a threshold. It was a yes or no situation where even if they had sort of less samples that were detectable for CMV, really they did not differ and were very different from the people who did not have any detectable CMV, who basically had a double rate of HIV DNA decline if there was no CMV. And then in addition, they looked at EBV, as I mentioned, which had a similar pattern, except that the EBV levels were associated with higher HIV DNA only when the CD4 to 8 ratio was less than 1, so when the immune system was more damaged, probably from the HIV infection. So when we're discussing opportunistic infections, unfortunately, as I mentioned, there is no data, and this idea was, we put together an opinion paper with some of my colleagues because we do see people with opportunistic infection in the clinic, and this idea came actually from a patient that I was seeing in clinic who had really persistent tuberculosis iris, immune reconstitution syndrome, and I was discussing with him how we're going to manage his iris, which was pretty persistent. And as I was trying to tell him the different options we were considering, he asked me whether he will be cured because he was reading in the news that there are cures for HIV infection, and his wife was coming from Africa the next few months, and he wanted to see whether he can be cured. And so I was obviously stunned and puzzled by the question, but then I realized that it is an important question because we really don't know specifically how opportunistic infections may be affecting the reservoir and whether these patients might be candidates for different remission strategies in the future when we get to the point of a simple and scalable really strategy. And hypothetically, this is a very important question because opportunistic infections have really a higher proportion of activated CD4 T cells. These obviously can contribute towards an HIV reservoir, and also you've heard from Serena about compartmentalization, which can be in CNS but also in other tissues that can be driven by local inflammatory responses to infections. And so really the question is how do specific co-infections or opportunistic infections may affect and their complications may be affecting the viral reservoir, and this is an area that I think we still need a lot of work to do. Now, it's hard to discuss about HIV and opportunistic infections and not mention TB, which is sort of the elephant in the room. We know that about 1/3 of people living with HIV have also latent tuberculosis. It's also a very common infection or presentation of HIV. It also accounts for 1 in 4 deaths in HIV, and obviously contributes substantially to HIV-associated morbidity and mortality. And we also have the more specific issue of IRIS on initiation of antiretroviral therapy, which is a very intense inflammatory response. So in this study, what we did actually, this was all, it was 270 patients in South Africa and Mexico who were all with advanced HIV infection, CD4 counts less than 100, many of them with opportunistic infections, but we wanted to see specifically whether tuberculosis has an impact on the inflammatory milieu of patients compared to patients who do not have tuberculosis. And you can see here that we found statistically significant differences in many of the inflammatory biomarkers that we tested, specifically C-reactive protein, D-dimer, which is a marker of coagulation, hyaluronic acid, a marker of tissue fibrosis, soluble CD14, IP10, and interferon gamma. So all of these markers seem to be higher actually in tuberculosis compared to non-tuberculosis, equally with advanced HIV infection and other opportunistic infections patients. And actually specifically for soluble CD14, which is a marker of monocyte activation, and interferon gamma, marker of T cell activation, this actually held even after adjustment for several other variables. So there's definitely more inflammation in tuberculosis that may have implications for HIV reservoir. Regarding T cell activation and IRIS specifically, this is, for example, the CD4 T cells of a patient prior to antiretroviral therapy initiation. You see very small production of inflammatory cytokines, but then during immune reconstitution syndrome, there is a huge proportion of the activated CD4 T cells that are producing cytokines. And this rapid expansion in the setting of early antiretroviral therapy, we think that may have some implications for the establishment of HIV reservoirs. And we are looking into this question now, and we will have some preliminary data at CROI. Moving to cryptococcal meningitis, and which may have implications for CNS reservoirs that were discussed by Serena before. Again, really not much data, but as it was mentioned, CNS is an important anatomic obstacle as a reservoir, and it is an open question that we don't have the answer to whether these specific CNS infections may be playing a role in seeding and further persistence of HIV in the CNS, and perhaps may or may not enhance compartmentalization. So we have just started a study in collaboration with David Bulwery at the University of Minnesota and David Meya at Makerere University in Uganda, trying to look at paired samples of plasma and CSF to look at HIV viral load in patients with cryptococcal meningitis, and perhaps look later on at sequencing of the virus and also address the question of compartmentalization. And as you see here, these are some of the preliminary data. The patients do have pretty high CSF viral loads that are very close to the plasma viral load. Usually it's a 1 log difference between CSF and plasma, and they seem to be higher when the patients had more cells into the CSF, again addressing this perhaps issue of compartmentalization. Now, as clinicians, we like to see things, and sometimes sampling of peripheral blood gives us a very small proportion of the cells and a snapshot of what is happening in the tissues. So I just wanted to bring up the topic of methods of visualizing inflammation, and I decided to discuss a little bit about the possibility of using PET scans to look at inflammation throughout the body of a patient. It was already mentioned by Serena, but with PET scans with FDG, we can actually characterize metabolic activity of the immune cells in the tissues. And this is just an example of a patient with HIV, and you can see all these little black spots are lymph nodes that are lighting up, and they have high uptake, and they're very metabolically active, which is usually a sign of intense inflammation. Okay, so the potential role of FDG PET with localizing CT in research may have different aspects. We could look at it in HIV and co-infections. It's already being used for HIV-related neoplasia, but also it could be used for non-AIDS complications such as cardiovascular disease and atherosclerosis or neuroinflammation. And I'm just going to bring as an example a study that was done by Priscilla Xu, who is a cardiologist at UCSF, and her focus was really to look more at arterial inflammation. But I think her study also showed some interesting findings about lymph nodes. So the people enrolled were from the UCSF SCOPE cohort, and she had mostly suppressed HIV-infected patients and some elite controllers and very few non-controllers, and also controls that were matched based on mostly cardiac risk scores. And then there were measurements of inflammatory markers as well as monocyte and T-cell activation by flow cytometry, and integrated HIV DNA looking specifically for HIV reservoir. And you can see here an example. This is a control showing really pretty quiescent lymph nodes in contrast to an HIV-infected subject that was not treated and was viremic, and you can see that they're lighting up in the axillary lymph nodes with pretty high values. Now, looking at the summary data, you can see that in the lymph nodes, there is obviously a lot of activity that seems to be graded based on the group that was studied, with a higher activity seen as sort of expected in the HIV untreated group, with lower activity in the untreated suppressed or elite controllers, and then slightly higher in the HIV treated on antiretroviral therapy suppressed. Interestingly, the level of the lymphoid inflammation, as I showed you, was higher in all the HIV groups compared to controls. And very important observation, I think, was that in the elite controllers specifically, there was a very strong correlation of the CD4 T cells harboring integrated DNA in peripheral blood with the lymph node inflammation and the measurements of the PET scan, suggesting the potential role of these tissues as reservoirs. So since they looked at the HIV-infected patients, they also looked whether these measurements correlated with HIV measurements, and they did find a positive correlation of the viral load with the lymph node activity, as well as the CD8 T cell count, and this was a positive correlation, and they found a negative correlation with the CD4 to 8 ratio. So I think this technique might be interesting to show us perhaps where to sample tissues to be able to study more tissue reservoirs. So we have started a study now at NIAID looking specifically at advanced patients, both at baseline and then shortly after suppression of the HIV viral load, and our goal is to perhaps do it also long-term on antiretroviral therapy. And this is just showing you an example of at baseline, you can see a lot of activity in several lymph nodes that really become very quickly more quiescent after antiretroviral therapy initiation. This is in sharp contrast to this patient who had disseminated Mycobacterium avium complex infection, and you can see some pulmonary nodules and mediastinal lymph nodes that lit up really like a Christmas tree after initiation of antiretroviral therapy, and developed immune reconstitution inflammatory syndrome. Now, I think everybody so far from the speakers has discussed the early antiretroviral therapy, which seems to be really a very, very good strategy to try to decrease as much as possible the viral reservoirs and try to put people at a very good position for potential cure or remission strategies. So the question that we addressed with the help of RV254 and the collaboration of the MHRP team and the Thai Red Cross was whether the very early antiretroviral therapy could actually abolish residual inflammation after antiretroviral therapy initiation. So what I'm showing you here is the C-reactive protein levels in this group. There was about 80 subjects that participated in RV254, and you can see that there was an increase of C-reactive protein levels compared to healthy HIV uninfected controls. And these levels quickly decreased with antiretroviral therapy initiation and normalized within 2 years of antiretroviral therapy, and were really not different from HIV uninfected controls, but they were significantly lower than chronic HIV subjects on antiretroviral therapy, also from Thailand. So this was a very, very encouraging observation. But when we looked at another marker of T-cell of monocyte activation, soluble CD14, we found that again there was a significant increase very early in early acute infection, but the levels actually failed to normalize after 2 years of antiretroviral therapy and remain higher than HIV uninfected controls. But again, a very optimistic finding was that they remain lower than chronic HIV infected subjects on antiretroviral therapy. And the different colors I forgot to mention represented different stages of early acute infection based on 4th generation immunoassay that could be translated to about 2, 3, or 4 weeks after infection. So it looks like some markers of immune activation and inflammation may not completely normalize even when treatment is initiated at very early infection. In contrast, as you've already seen from Nicolas' talk, the impact on viral reservoir is very positive, but we also need to know that the viral reservoir is established very early in infection. And looking again here at the different stages, it was obviously lower at the first stage compared to the other two. And interestingly enough, because I showed you data from soluble CD14, you can see that the integrated HIV DNA in PBMC is strongly correlated with the plasma measurements of soluble CD14, again giving you this connection between inflammation and viral reservoirs. So in summary, what I showed you is that inflammation and immune activation are critical in HIV persistence. Co-infections, including opportunistic infections, could impact significantly T-cell activation and expansion and possibly compartmentalization, and that may have important implications for tissue viral reservoirs. I think for scalable cure strategies, we really have to evaluate systematically the impact of co-infections, because personally, I don't know a lot of HIV-infected subjects who have just HIV. There are STDs, there's hepatitis C, there is CMV, and then there's the end of the spectrum opportunistic infections. So really HIV is an infection of co-infections. Imaging modalities and tissue biopsies may be helpful to address the question of where do we need to target and sample, and that may help us tailor strategies in the future. And then obviously, like everybody else has agreed, earlier diagnosis and treatment of both HIV and co-infections should be the most immediate goal. Treating co-infections may have an impact. There are studies in HCV, for example, showing that after treatment of hepatitis C in co-infected patients can decrease soluble biomarkers of inflammation. And there are even studies in HIV treating CMV that show that you can even decrease T-cell activation. And more specifically, what we brought up in the opinion paper in the Journal of Virus Eradication, we think that in the future cure and remission studies should really try to include a very detailed co-infection history of the study participants to start to address if and how these co-infections and their treatment can impact reservoir size and persistence. We think that compartmentalization may be particularly relevant in cases of co-infections and should be addressed specifically in co-infected patients. Obviously, the potential impact of iris, which causes both a systemic and local inflammatory response. And then it is important, I think, to start going local in some of these studies, because not everything is going to be generalizable. So certain geographic locations have particular infections, they have differences in virus type, they have differences in genetics, microbiome, and so all these components of inflammation may have impact on reservoirs, and then studies that are done in a specific country, in a specific set of patients, may not be applicable or generalizable in other countries. So I would like to thank for your attention and acknowledge obviously my team and the Thai collaborators and other collaborators. Thank you.
Thank you so much.